Hello, everyone, and welcome to today's webinar, The Role of Pulsed Radiofrequency Energy for Treatment of Pain. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You may have joined the presentation listening using your computer speaker system by default. If you'd prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your question at any time during the presentation and we will address them at the end. I would now like to introduce Dr. Ravi Mapuri. Dr. Mapuri specializes in pain management and practices in Naples, Florida. He graduated from Lake Erie College of Osteopathic Medicine with his medical degree in 2011. He completed a fellowship at the University of Nebraska and residency at the University of California, Irvine, which is affiliated with the Veterans Affairs Medical Center in Long Beach. He has a background in the research of pulsed radiofrequency. He is a member of the American Academy of Pain Medicine. Dr. Mapuri is both board certified in pain medicine and physical medicine and rehabilitation. Go ahead and take it away, doctor.
All right, thank you for the intro, Nikki. Afternoon, everyone. Thank you for joining us on this webinar presentation. So basically, the topic I'm going over today is the role of pulse radiofrequency energy for the treatment of pain. And we'll kind of go over what that is and some of the evidence and things related to it. You know, as a background again on myself, I'm a practicing pain management physician. And so a lot of my take might be in relation to how it applies to me as a pain management and how it may apply to you as well. Also, I've done some research in a few different IRB studies related to pulse radiofrequency energy and different approaches using percutaneous and transcutaneous. So we'll begin this presentation. So this is kind of a brief overview of the agenda, you know, going over pretty much what is pulse radiofrequency, how it works, the mechanism of action, why do we even need pulse radiofrequency, and what is the current evidence from a literature standpoint in regards to pulse radiofrequency. So kind of going over, you know, pulse radiofrequency is a method of pain management by applying short pulses of radiofrequency signals, and these signals then will generate an electromagnetic field. One of the big concepts of what makes it pulsed versus non-pulsed is the temperature. So, you know, heat averages 42 degrees Celsius or less. So in essence, this is non-ablative. If it was going up to the higher temperatures above 42, it may have more ablative properties, can damage nerves. So that's one of the differences, that it's staying below 42 degrees Celsius. And then, you know, why are we calling it pulsed? And this kind of shows you like a diagram of how the thing works. You know, between each pulse is the frequency, you know, and then the height of it represents the amplitude. But then within each pulse, it's like a burst of a bunch of signals, and then it stops in a burst of a bunch of signals. And so that's kind of what this is resembling. And so the pulse width represents the width of one of these small little pulses. And it's important to kind of discuss it a little bit just because these settings can be adjusted when you're doing that, and it may have a difference in clinical outcome. So again, you know, it's non-invasive, non-thermal method of delivering electromagnetic energy. Usually the frequency ranges from 1 to 1,000 hertz, and the bursts from the pulse that we talked about earlier can be from 10 microseconds to 1 microsecond. Making it non-ablative in approach. So, you know, we'll talk about this later on, this type of slide, but I just kind of giving you an example so that it kind of drives home that the settings will matter. You know, there was one study that was done where you were comparing people with back pain and leg pain from, you know, like post-laminectomy type syndrome or failed back syndrome. And you know, if you change the pulse width, you know, this one was showing us in this study, you could see that there's a difference in clinical outcome. So going at 42 microseconds, you know, the average pain scores went from 4.9 to 2.9, as opposed to just 38 microseconds in width. And the same thing applied in the leg pain. You can see that in these graphs, there was a superiority using 42 microseconds over 38 after a 60-day trial. So energetics have some influence on it. And again, there's multiple settings that can be tweaked, which I was kind of showing you earlier in that earlier graph. So one of the devices that we're mostly focusing on in today's lecture is Provent, which is a non-thermal carrier frequency of 27.12 megahertz. And this is applied for 30 minutes. The settings on this particular device is at 42 microseconds in pulse width and 1 kilohertz. This generates an electric field of 591 volts per meter at a depth of 5 centimeters. The electric field strength does have importance, because in all these settings at the end of the day help form that type of electric field and magnetic fields that come with it too as well. And a lot of that's maybe the main source of where the benefits are coming, because if you need enough field strength to depolarize the cells and cause reaction. So how much it produces and at what depth will make a difference. And again, you can just tweak the settings to kind of create that. And that's sort of what this device has done, is come with pre-tweaked settings that will generate at that field, which makes it convenient. So kind of here's a picture of it. It's a dual field, high energy electromagnetic therapy. Pretty much, sensation free when you put it on. It's not like you're feeling like large pain or anything when you apply the device onto it. So it's mostly paresthesia free. So what is the mechanism of when you're using pulsed radio frequency energy? There's multiple methods of how it may be beneficial. Still, of course, always more literature, more research coming out in terms of how it can be utilized and what it's working on. But increasing endogenous opioids, increasing matrix metalloproteases, chondrocyte proliferation. And you'll notice that those two, when you're talking about matrix metalloproteases and chondrocyte proliferation, that sometimes has to do with wound healing stuff too, which there was some prior studies in relation to pulsed radio frequency. But for the premise of this lecture, we're mostly going to be referencing in terms of neuromodulation and reducing pain levels. Also reduces microglial activation, that's more of a pain concept, and enhancing the noradrenergic and serotonergic inhibitory pathways. So this is just kind of showing you some of the titles of some of the literatures that are kind of talking about the mechanisms. It's not just me picking random things, that there were studies, and that's where a lot of these genes and growth factors and stuff were pulled from. So here's just an example of some of the sources published. But here's another way of looking at it in a different diagram. In terms of the pain component for pulsed radio frequency, increasing the endogenous opioids, which has a more of an anti-nociceptive effect, helps reduce the pain, increase endorphins, dynorphins. Then you have the part that may help with the anti-inflammatory component, the cytokine and edema-related genes. So, interleukins are an inflammatory component. Aquaporins are channels typically in the dorsal root ganglion, which have a lot to do with stimulation of pain. Then there's resolvins, like it sounds like, resolve the anti-inflammatory part. That's when they're released to help resolve inflammation during that phase of the inflammatory cycle. And then also here's the growth factors with resolution that we talked about earlier, increasing extracellular matrix and growth factors. So now going on to the next, what is the importance of pain treatments and stuff? And ideally it'd be nice if we could just put people through an entire electric field like this, although nothing exists like that. But, maybe one day in the future. So the importance is kind of based on, we need more treatments in the pain realm. So the VA in particular has been fairly aggressive in relation to the opioid safety initiative. They definitely took some big steps on making some recommendations and changing the way opioids are used. So in the VA, many of you may be already aware that they've made large cuts into the amount of opioid prescriptions, in many cases taken a lot of their patients off of it, just based off of studies and evidence in terms of treating things chronically. That's now, just to be clear, the safety initiative did not say not to prescribe opioids ever, but that there's a lot of limitation essentially in the use of opioids for chronic pain because the body adapts to these things over time. And so, changes are made. And so a lot's been done. It's a quite large initiative that applies to all the VA. But then again, academic centers and plenty of other in the industry are trying to make cuts into the opioids because they may not be as effective as once originally thought. Again, not saying that they don't have a role, but maybe not as much of a role as it used to be in the past. Pain affects quality of life and consumes healthcare resources. This is a study where you're taking chronic pain patients and measuring their quality of life and how many of them think they're unable to perform it to the same degree that they used to. It affects exercise, sleep, hobbies, chores, socializing, walking, sex, concentration, relationships, work, and childcare. So a lot of people feel with chronic pain that these activities are drastically inhibited, which is what this slide's trying to reflect. Particular in the VA, 90% of patients with pain are being managed by primary care. And as such, it's one of the most costly disorders treated by the VA. So having alternative modalities to treating pain patients is important. In addition, it's a little bit easier for me as a pain management doctor because that's all I get to focus on. But, since primary care is handling that, there needs to be options for primary care to be able to prescribe to in the interim before maybe a patient's able to see someone like me in pain management and go on to additional therapies. So having devices, different medications that are non-opioid based that can help reduce pain are helpful, that are easily prescribable. So now talking about the Provent device in particular, we'll kind of talk about how it's used. It's fairly easy device. It's designed to be used at home, which is among the lowest cost care setting that you can have. You've just placed these disposable applicators onto a treatment pad, and then basically you're placing it over the site of pain, and you just push the start button, plug in the device, and it goes for 30 minutes, and you're doing it twice a day typically. And it can be applied through dressings and clothing, although then again, if there's no wound infection or any reason you can't set it directly over the site, you probably would rather do that than instead of over clothing, because again, it puts the device closer to the source of pain, because depth does make a difference. This is an FDA cleared device with a 510K indication, with its labeling through the FDA to be used in post-operative pain, edema of soft tissues. So typically in my particular practice, we're using it for chronic post-operative pain for the main labeling based on FDA clearance. So what is the evidence, in terms of pulsed radiofrequency electromagnetic energy? So we'll kind of go over some articles and stuff of where it has been shown to have some benefits. And then of course you'll be able to ask questions at the end regarding it. So this is one that is talking about case reports. So, we'll start off with some of it, in this particular 15 case reports, they used it across different indications, plantar fasciotomies, post-cervical fusions, lumbar fusions, post-chest surgery, a lot of post-surgical indications. And basically in this particular study, it was kind of showing, as preliminary improvements, that their pain was before Provent, after going down from a 10 to 2, from a 5 to 9 to a 0. But pretty much in all the cases, there was improvement. But I guess the more interesting part that can be derived from the case reports, because obviously case reports have limited evidence, is that patients were having medication changes where they were able to cut back on it and reduce. And in a lot of these cases, there were significant cuts, if not into the what they were taking after using Provent. So I think that was the bigger take-home message for me, that it may have some influence on reducing that. So then another one, and this is a study that I participated in and designed and developed along with one of my mentors, Dr. Patricia Nance. It was we did a retrospective case series, an IRB approved study at VA Long Beach. And part of the reason that we decided to do is because we were treating the patients with it, but we wanted something objective to see, are they really getting benefit from it, if we were to take a look at it, because we already had a design when we would prescribe it, when we would follow up with it. It was already as if a study was being done, but we've never actually sat down and compared them all. So we got IRB approval to do it, and then was measuring based on when we would follow up with the patients just routinely as part of our treatment, not study related when we first decided to do this. So because we were treating them, we were measuring them right after the trial period, and then at 4 weeks and 8 weeks, and we compared all the numeric pain scores that we had to it. And it did show improvement, and we're kind of going to go over into more details about it. But at the Long Beach VA, it kind of became known as the Long Beach protocol on how we would do these trial phases and issue to the patients. Basically, it's similar to what I told you. Before you issue the device to the patient to take home, they would come in, use the device for 30 minutes, and if they're reporting pain relief, then we would issue it to them to take for 30 days, and we'd extend it up to 60 days. Nowadays, it can be extended even further up to potentially 120 days, but at the time of this design, most of them would give for 30 days, and if they asked to extend it to 60 days, we would do that for them too as well, up to their preference if they wanted to do an additional extension. And so that's sort of how we did our protocol. And it's still being used for multiple other ways, but that just gives you an example of how you can decide whether to issue someone the device is by giving them a trial phase. Here's the numeric pain scores across those 40 patients. Initially, numeric pain score 7.9. After the trial, it did have some improvement to 5.6 with and then from the post-trial to 4 weeks, there was also improvement. And then from 4 weeks to 8 weeks, there was further improvement. So we were seeing continuous stream of, essentially like a linear type improvement. And the P values, were very strongly in favor that it was quite statistically significant, with P001 and then P.006, which is pretty good. So we were glad to see that it was kind of showing statistical improvement. Here's another thing. When we kind of broke down all the different diagnoses that we were using, and then just kind of comparing their initial pain scores post-trial, 1 month and 2 months. And you can see that in most of the diagnoses, there was somewhat of a trend of improvement. That being said, the power of this, I wouldn't say is enough to draw like a statistical, that's statistically beneficial for each diagnosis, but it kind of is showing the trends. The main statistics was when we compared them overall, where we could show that statistically it was making a difference. So going on to another study, published by Sorel. This is a group of patients who had received post-operative pain after lumbar surgeries, and they were measured at baseline in over 60 days. And this also is related to that energetic slide I showed you earlier, improvement. So they actually, randomized into a sham who really wasn't receiving the actual treatment, but they would put the device and not really run it at the right sense, and then do it to an active. And you can see that there was improvement, technically in both the active and sham, but there was a much significant improvement into the active, and this one was actually statistical improvement compared to the sham. Additionally, the study also measured C-reactive protein, which is kind of interesting because sometimes pain can be from an inflammatory component. So this is sort of a way of doing a blood test to see what is their inflammation levels. And when they're running the device, that it actually had some decrease in their C-reactive proteins before and after. Well, when they ran the sham, it actually went the other degree and went up. As a reminder, CRP Normal is considered usually 3 or less, but it also depends, of course, on the lab and error and which component of CRP they're measuring. But for this particular one, 3 and less is usually what is considered normal. So there was some improvement with that in the active and none to the sham. And this kind of shows it all together when you're kind of comparing at the 42 milliseconds, the experimental 38 and sham. There's improvement with the Provent in terms of the pain scores, and the this one's for CRP, and then this one's a reflection of the pain scores. Much more better at the 42 microseconds versus sham and experimental, which were not very statistically significant. Here's another article, that was published by Murray Tavner, using transcutaneous pulse radiofrequency treatment. This one, their device that they used for this was sort of a makeshift device using Neurotherm. I don't believe it's something that's commercially available, but basically pain management physicians are used to having devices in their clinic where if we wanted to do like percutaneous pulse radiofrequency, we could do with the needle. Of course, insurance typically won't cover those type of procedures. But in this one, they used that device and was able to attach it to a transcutaneous-based device to make it work for the purpose of this studies. So it was randomized, double-blinded, placebo-controlled, and 50 patients were divided into sham versus transcutaneous pulse radiofrequency. And they started to do measurements and comparing, after having them do walks at 20 meters versus 400 meters and measuring their visual analog scale on a scale of 0 to 100. And in this one, it showed improvement in the active versus the sham. This chart's a little bit hard to read, but basically they're showing that at rest, that in the shams at 1 week and 4 week, the pain's kind of going up. And this is reflection of the change, not the actual score. So it improved by 2 points in the sham here for 20 meters and actually was going up in pain score at the 400. And at 4 weeks, not too much of a change. Here in the active, where they were actually using the device to give pulse radiofrequency, you had negative points, which means there was improvement, of 1, 15, and 10. Remember, this is on a scale of 100. And same at 4 weeks compared to the baseline, it was still showing improvement. So with continued use, between 1 week and 4 weeks, there was definitely improvements. And this one was measuring, it has a way of measuring function too, because they're measuring the how far they're walking. And this was applied to patients who had total knee replacements, who are waiting for it. So before they even got it, they said, let's try this before we start giving them and see how they respond to it. So Tavner, using the same type of device, actually did another study, kind of in concept, prior to surgery. These were patients who were booked for surgery. And this one is measuring again, the visual analog scales. So 51 patients, and then they're measuring them at 4 weeks and 12 weeks and kind of comparing how their pain scores were. So the shams are these ones in blue here, and they're, you can see it's very small changes, and in fact, not that's significant, which the study didn't show any statistical significance. Where it's changed, but here you're seeing drops compared to at nighttime measuring the scores. There was a drop from the original of 56.5 going down to 32 and 39. At rest, which is usually typically people aren't as pain when they're just sitting doing nothing, but there still is improvement there. And then doing activity, dropping from 69 to 48 in the scale of out of a scale of 100 with activities. So this is the advantage of this one, is that these are double-blinded, placebo-controlled trials, kind of showing this type of evidence. And then, there's a course that was provided to me by Regenesis, whom helps manufacture the Provent, pulling data from their own internal So they have patient care coordinators and nurses who track these outcomes, including the pain relief and quality of life. And when they were using those type of, they're just analyzing the data, and 74% of their internal data is showing that patients were having reduced pain scores. But of that 26% who wasn't getting the benefit, they were showing that 72% of that group had improvement in their daily activities. And also that same group of that 26%, that they were also 40% of them had improvement in their sleep. So functional gains still are important into even if they didn't get the numeric pain score change. And this is in terms of also internal Regenesis data, where a lot of it's probably collected by the representatives, asking them, are they satisfied with Provent and the services and the follow-up? And this is kind of showing the data of 99% for most of it, and then would they recommend Provent to others? 96%, which is really high. And this is data from 6,584 patients from 2009 to 2018. And in addition, Regence can help monitor patient treatment compliance in two ways. They have patient care coordinators that you can always reach out to, if you have questions about the coding and insurance, and also, but the biggest part is helping the patients, training them how to use it, maybe sometimes doing the trial testing for you, and also the disposable applicator covers and stuff, and renewing that, and making sure that month to month patients have the adequate amount of applicators that they run out, and it's somebody that they can contact directly, as opposed to sometimes having just to contact the physician. So it kind of makes your life a little bit easier. So a lot of this particular topic was focused on the transcutaneous approach for pulsed radiofrequency. But there are other methods, but this one is among the easiest way for a patient to receive it that doesn't require invasive, injections into the patient. So here's a list of several of the references that I utilized in terms of the evidence. And hopefully this was informative, but I tried to leave a lot of time to kind of go over questions that you might have in regards to any form of pulsed radiofrequency that I'm able to answer. So I'll leave it up to you guys for any questions that you have for me.
Okay, great. Thank you, Dr. Merpuri. We're now going to begin answering the questions submitted during today's presentation. So as a reminder, you can still submit questions to the questions pane of the attendee control panel. So our first question is, what patient diagnosis do you typically utilize pulsed radiofrequency energy on in practice the most?
So for me personally, as a interventional pain management, the biggest referral source that we get is typically back pain and neck pain. So a lot of the back pain patients who have tried treatment stuff, this is something that I would be more readily inclined to utilize. Failed back syndrome is certainly something, especially because multiple options have failed, and it's a great option. But then again, you don't have to make it, a second or third line. It can be among the first line. I also like to use it as encouragement to get some patients off of opioids. A lot of the time they don't want to transition off the opioids because they don't have an alternative to use. And this is something, when you're giving people different methods, that it will help facilitate that process.
Okay, great, thank you. And when using Provent, do you have patients receive other therapies in addition to it?
Yes, I mean, to be honest, in most cases, my patients at least, they're always receiving multiple therapies. The standard of pain management is still multimodal care, which means you don't rely just on medicines, physical therapy, injections, electromagnetic devices. It usually requires a combination. So in prayer, just because they're receiving, Provent doesn't mean I'm not doing, facet injections or epidurals, or not having them being sent to surgery, even if it's indicated. it's in most cases I'm using it in conjunction with other treatments. And keep in mind, no one's trying to say that if you use this device, it's taking someone's pain down from a 10 to 1 and they don't need anything else. It's something that is a great adjunct for reducing the pain. You saw the scores in our study. Maybe it's going from a 7 to a 3 or a 4. So that's still very helpful from a patient, especially when you're living in chronic pain day in and day out. But having adjuncts is always, an encouragement to use for almost any diagnosis across the board.
Okay, thank you. And what are your thoughts on PRF therapy for the treatment of significant pressure areas?
So when you say significant pressure areas, I'm presuming that the question is making reference to like where people might be prone to pressure ulcers or wounds in that area. If the area is painful, I think it's something that can be considered. If it's highly irritated or like an actual open wound, I even though this has some source going into wound care where there were some prior studies using pulsed electro, because of the FDA labeling and indication, I would be a little bit hesitant to use it over an open wound. So it's not typically an area I target. But if it's just a common area that's sealed and closed, I think it would be a reasonable option to use. If you're using on the sacrum or the heels or back of the head, as long as it's not open wound or actively infected. And again, I'm assuming the question was making reference to those pressure-prone areas for patients who have less mobilization in those areas.
Okay, great. And do you notice an increase in general pain in people that have issues such as fibromyalgia? Any systematic effects?
For pulse radiofrequency energy, no, I think it's actually, I have some fibromyalgia patients I have used it on. In fact, that one slide where I had where that whole guy was in the electro field, I think would be great for a fibromyalgia patient. They normally, my experience has been good. Again, though, it's not like I have a large sample or I can recall a study making reference to fibromyalgia in particular. But fibromyalgia patients, the core for treatment is, opioids are not the most ideal treatment for fibromyalgia patients because whatever the reason, there's an oversensitization to pain. So opioids aren't the great treatment typically for that. And usually they're medication resistant. Of course, there are the FDA labeled medications. So naturally, I would try those first, the FDA labeled fibromyalgia med. But using that in addition, if they're having pain that stands out in one area more than another, then I do target that, whether it's with injections or Provent. So if they're fibromyalgia, but they're like, my back pain is 70% more than the rest of my body, I think it would be a beneficial treatment. Again, assuming that they have an area that stands out. If it's just total body pain and everywhere is just as equal as another, I don't think it's going to generate the result you would want, especially because how could you possibly cover all that? But I can say from experience, I've seen benefit in fibromyalgia patients who've had neck pain or back pain stand out more than another, and it has been successful for me personally. Again, I can't recall a study that has been done yet on that particularly.
Okay, great. And can it be used for back pain that is non-operative to replace use of opiates in long term?
Can you repeat that question one more time?
Yeah, so can it be used for back pain that is non-operative to replace use of opiates in long term?
Yes, I mean, in fact, I think, to be honest, that would be a great indication to utilize it for. A lot of conditions, medically are not necessarily, surgical. There's obviously the ones that stand out, when pinched nerves and weakness in the legs and stuff, those are standout surgical. But for back pain in particular, that's not necessarily going to surgery, I think it's a great option and is one of the biggest indicators to consider. But you may want to use that again as an adjunct with other treatments, whether it's interventional injections or stuff, because it will depend sometimes on if you want to issue the device to get it coded to be issued, sometimes it needs to go under chronic post-procedural pain. So you usually have to try an intervention or something in many cases to get it covered. But if that wasn't the case, it still could be used right away if it was covered by their insurance plan.
Okay, thank you. And would you use PRFE Provent before ablative procedure or after?
So in those, if I think they're pain, so ablative therapy typically implies that you feel strongly that it's facet origin. So me personally, it can be used as both, and you can give the patient the option. I think is a reasonable thing. But if I feel strongly that the pain source is at those facet joints, as an interventional pain manager, of course I'm gonna be a little bit biased because that's sort of in my wheelhouse what we do. I would target those joints in particular because if you ablate it, the data on it is that you might get 6 months to a year after ablating it. So I think if it's strongly that. Now, if you think it's more than facet origin, and you're like, well, I think it's maybe 40% facets and 60% muscle spasm, then I think you might find a benefit of using Provent over the ablative therapy. But if I feel that the source is facet in origin, then I would probably go for the ablation technique. But then again, you'll do a test block first anyways to kind of help confirm or refute that it is facet in origin. And so that's not what I would use. And then, sometimes people will do, since you brought up facets, pulsed radiofrequency in the facets itself using percutaneous approach, but insurance typically does not cover that anymore either. So mostly everyone is doing ablative approaches for facet, unless you're using a transcutaneous approach such as Provent.
Okay, thank you. And someone is asking, and is this available overseas? Wait, is this available in overseas areas that get treatment at VA? And I know Scott, our organizer, if you're not sure, he just let us know that it's not available overseas, only outside US, or it's not available, or it is VA overseas. It looks like Scott is saying.
Okay.
And then, so kind of a follow-up, I'm listening in the UK. Do you know of any similar studies, treatments here?
Where they're using, so in terms of whether the UK is using Provent in particular or pulsed radiofrequency, I don't know about the transcutaneous device because Provent is, a patented device at specific settings, and so I wouldn't know if that. To my knowledge, I don't know if it's available in the UK, that particular device or any competitor. But in terms of pulsed radiofrequency, the concept I'm quite sure is being used in the VA because it's not just a US-based concept, but most of those I suspect are going to be in reference to the percutaneous approach, where you can take a needle and you place it into the site of pathology and then run it at a pulsed radiofrequency level. But that was being done a lot more historically in the US, but when insurance stopped covering it, it started to kind of fade away in its use. But I have read pulsed radiofrequency being used percutaneously in multiple countries, so I'd imagine it would apply to the UK too as well, because I know they do ablative procedures there.
Okay, thank you. And then PRP injections or steroid in conjunction with Provent, thoughts?
So I think both are fine. Doing steroid injection and Provent, you probably don't, those can be done quite close together. If you're doing them a day apart, for me, I wouldn't anticipate there would be too much of an issue other than just trying to wait to see if the steroid shot helped. in terms of PRP or platelet-rich plasma, most of the time when you inject platelet-rich plasma, you're inducing an intentional inflammatory reaction. So if you are going to use Provent in conjunction with that, you're probably going to wait at least 2 to 4 weeks. Of course, this is, not exactly scientifically determined, but because Provent may have an anti-inflammatory component. So you don't want to mix an anti-inflammatory with a pro-inflammatory component like platelet-rich plasma. So if it was me in my practice personally, I would probably give them the PRP, and if then they still had residual pain, 4 weeks later, then I would use the Provent, but not together at the exact same dates within the first 2 to 4 weeks, because you want the tissue to heal, and that's inflammatory for platelet-rich plasma.
Okay, awesome. So I believe that was our last question. I do not see any more questions coming through. So I do want to thank everybody for joining today, and thank you very much, Dr. Ravi Mirpuri, for an excellent presentation. And this does conclude our webinar, and I hope you all have a great day.
All right, thank you for having me.